Hi everyone and welcome in the 15th webinar of our series. Let me introduce my colleague Maud Juqua, who will chair this webinar. Maud is a senior health economist at the GFF Secretariat, where she leads the Human Resources for Health technical agenda. She has over 15 years of experience in health financing, human resources for health, and maternal, adolescent, and child health across Africa. She also co-chairs the CHDP Health Financing Technical Working Group with UNICEF. Maud, the floor is yours.
Good morning, good afternoon, everyone, wherever you are for today's webinar. It's great to see so many participants today. Let me quickly walk you through what will be the agenda for today's webinar on institutionalization of community health programs through purchasing mechanism. First, we'll hear from Fauzia from UNICEF, some introductory remarks. Then we'll have a framing presentation from Solène from Financing Alliance for Health. We will continue with the country panel with a representative from Burkina Faso and Kenya. And we'll also hear from a community health worker from Kenya, Dr. Margaret Odera. And then we'll open for a bit less than 30 minutes of Q&A before closing our session with our colleague from Global Fund, Nick Oliphant. So without further delay, let me introduce Fauzia Shafiq from UNICEF. Fauzia is the Associate Director for Health at UNICEF headquarters in New York, and she oversees global work on maternal and newborn child and adolescent health, primary health care and health system strengthening, and she's providing global leadership on community health systems. She has more than 20-year experience of public health across a humanitarian and development context, including leading UNICEF health programs in Afghanistan and Yemen and global health action in humanitarian and emergency setting. She holds an MBBS and a Master of Science in Public Health. So it's an honor to give you the floor, Fauzia, for some introduction remarks. Over to you, Fauzia.
Thank you, Maud. And a very good morning, good afternoon, and good evening to colleagues who are joining us from around the world. Like you, Maud, I am very pleased to be here, and even more so to welcome all the colleagues online to the session. And we are truly inspired to see such strong interest with hundreds of policymakers and leaders from around the world who had registered and who have joined us today, highlighting how critical the issue of community health workforce financing is for the national agendas. Let me just begin with our key message for the day. Institutionalizing community health programs and fully integrating them into national primary healthcare systems, it is not just the right technical option. It is in fact a strategic imperative for countries that are committed to universal health coverage and to sustainable health outcomes. Now, most of you are aware of this. The evidence is truly compelling. But let me share with you a recent piece of evidence. UNICEF recently commissioned a major global return on investment analysis led by a team from Johns Hopkins University in consultation with more than 30 global experts from some of the key partners. This work shows that for every dollar that we invest in community health workers, there is an economic return of over $11 through better health outcomes, better economic productivity, and system resilience. This underscores not only the human impact of community health programs, but also their economic value as a smart investment for countries to make in their health systems. Now, this case is further reinforced by decades of evidence on community-based primary health care. Reviews of global data going back decades show that strong community-based platforms have the potential to avert a vast majority of deaths that occur amongst children. Up to 97%. Let me repeat that. Up to 97% of deaths in children aged 1 to 59 months, and nearly half of those in newborns in high mortality settings. Now, this reflects the fact that many of the leading causes of mortality during early life, pneumonia, diarrhea, malaria, neonatal infections, complications of prematurity, they can be prevented or mitigated through outreach, early detection, counseling, timely referral, and linkage to facility care when supported by strong community systems. Now, increasingly, there is also a case to be made for investing in community systems for better health outcomes in all age groups, adults included. These data offer us more than just academic insights. They point to a real world opportunity for countries where when community health workers are integrated into health systems with adequate planning, with good supervision, with supplies and financing, they become a driving force in reducing morbidity and mortality in their communities and improving health service reach and equity. Now, having said this, we also need to be clear. Financing community health systems is not just about community health workers' salaries. It is about sustainable system-wide investments in training, in supervision, in digital tools, in commodities, in data systems, in quality assurance, and most importantly, in supportive policy frameworks. Very often we see that the investments focus on isolated line items rather than a holistic system that community health workers need to perform. So we need to move away from this isolated line item approach. Now, another key reality is that there is no one size fits all model. Employment conditions, compensation structures, and incentive frameworks vary widely across countries depending on the context, or depending on the governance arrangements, and on fiscal settings. Our first speaker today, will share details of some of the evidence that I've just referred to and more, but we'll also talk about the biggest challenge that we face. How do we move from donor-driven, donor-funded community systems to government-owned and funded ones? But today's webinar is not designed to prescribe just one single template. So we will share lessons from diverse country-led approaches. In particular, we will explore how Kenya and Burkina Faso are restructuring and financing their community health services and what we can learn from their experience. We will also hear from community health worker champion, whose voice reminds us that behind every policy discussion are real people who are delivering care, who are building trust in their communities, and they are saving lives within homes and within communities. Our conversation today is also directly aligned with the Bangkok Call to Action, which calls on governments and partners to move beyond project-based approaches towards institutionalized, nationally led community health systems that are supported by sustainable financing, that are supported by supportive technology, by trust-based inclusion, and very clear links to formal health systems. At UNICEF and within the Community Health Delivery Partnership, we stand ready to support countries as you design, finance, and implement these systems as part of robust primary healthcare foundation. We believe this is central to achieving universal health coverage. This is central to strengthening health security, and it is central to ensuring that no child is left behind. I look forward to a really rich exchange in the next hour and a half. Thank you, and back to you, Maud.
Thank you very much, Fauzia, for this very inspiring introduction. And let me now hand it over to Solène that will share some framing presentation and share the global evidence on purchasing for community health program. First, let me quickly introduce Solène Scotney, who is a health financing and political economy expert at the Financing Alliance for Health, with more than 15 years of experience in primary health care, health system strengthening, and global health partnership. She worked at the Global Fund on the new funding model and at CHI-led vaccine program expansion in Africa, market shaping initiative, and served as country director in Cambodia and Asia Pacific Regional Advisor. She was awarded Cambodia's Grand Cambodian Knight Medal, co-chaired the Global Fund CCM Oversight Committee, and serves on Gavi's Independent Review Committee. Solène holds master degrees from LSE and Sciences Po. We're very glad that Solène will be able to share the global evidence on community health purchasing mechanism. Over to you, Solène.
Hello, everyone. And I'm really happy today to be talking about strategic purchasing for community health worker programs. And by this, I mean, how can governments align funding with population needs in a way that makes the maximal use of limited resources, but also improves service delivery for health impacts? And I'll be talking about three things. First, the community health worker investment paradox. Secondly, looking at a community health worker strategic purchasing framework and the different options that are available to countries there. And then I'll reflect on some of the lessons learned and the way forward from here. First, the community health worker paradox. So as Fuzia said, we have, on the one hand, a program which is incredibly high return on investment, with over time and time again, a review of over 300 scenarios by the Community Health Impact Coalition also showed that in over 80% of cases, community health worker programs were cost effective against the alternative across disease areas: maternal and child health, infectious diseases, non-communicable diseases. And this is because community health programs occupy a unique place at the intersection of supply and demand. On the supply side, as Fuzia mentioned, they extend the reach of essential services and provide equity in that regard. But on the demand side, they're also an incredibly important tool for social accountability, but also for public financial management, because they can gather the feedback from the communities that they serve and within which they live on whether, for instance, health commodities and health services are really available as they should be at the nearby primary health facility. Here is the paradox. To be able to unlock this health impact, the community health worker programs need to have what the Community Health Impact Coalition calls the 4 S's. They need to be skilled, they need to be supervised, they need to be supplied, and last but not least, they need to be salaried. But this is not the reality of most community health programs still today. When we looked at, as a financing alliance just before COVID, at domestic funding for community health programs, we found that this was already generally less than 10% of primary healthcare funding from domestic sources, which is already too small a pie of a health budget. So who has this left as the main purchaser of community health programs? External donors. And this is a big risk to community health programs. Why? Well, first, because they're subject to big variations. And you can see how here a study we did on over time, the fluctuations in this donor budgets for community health. And secondly, because donor funding has been mostly vertical. 76% of funding to community health programs between 2016 and 2022 was vertical. And by this, I mean tagged to specific disease areas, as opposed to an integrated program reaching people with an integrated set of services. Now, how can we move away from this reality to actually unlock the power of the community health investments and overcome this paradox of an unfunded high return on investment and reach UHC? This is where strategic purchasing comes in. And I'll be talking through this framework from Hamali et al., where we first will look at the purchasing arrangements: what to purchase, from whom to purchase, how to purchase. And then we're also going to be talking about the need to look at how then these purchasing arrangements deliver impacts, and in particular, measuring health impacts on health indicators around access, quality, equity, efficiency. How are they raising health outcomes at the community and primary health level? And really, the focus of a lot of community health programs today is optimization. And by this, I mean looking at how the impact is generated and how we can use this feedback loop, this orange arrow here, to actually influence improved purchasing arrangements around community health worker programs. Let's start with what should be purchased from community health workers. Well, here purchasers, and by this I mean ministries of health and ministries of finance, need to think through first, what is the essential benefit package that they want to deliver to their population? And from this, what can be delivered at health facility level, or what is actually ideal to be delivered at the community health level? And then accordingly, what can be task shifted safely with training and supervision to community health workers? Now, what we've seen is that historically, a lot of community health worker programs were primarily referrals and education. But as we move, we see that what communities values is when they can move to a more meaningful package in the eyes of the community, where they provide services beyond referrals. First, preventative and basic care, including, very importantly, addressing the social determinants of health. But then even thinking about an expanded packages of services on areas that are still difficult for ministries of health to achieve their targets, such as malnutrition, such as chronic care, where time and time again studies have shown that community care health workers can not only test, but also ensure strong adherence, and maternal and child health. Also, we've seen that with climate change and epidemics, community health workers have an important role to play, both as early warning signals, but also as first responders. Another evolution, they're taking on roles as on social health insurance, and in particular ensuring that the most vulnerable get registered in the wake towards UHC. And last, an expanded role on civil registration and vital statistics, so that populations, including local governments, know each of the households that they serve. But as this package expands, so does the need to ensure that the services that need to be provided are actually bundled in terms of financing. Fuzia alluded to this, that the commodities are actually reaching not only the health facility, but the last mile and the community health workers, and that community health promoters are supervised to do so at high levels of quality. So let's talk about from whom to purchase now. So from whom to purchase, there is a variety of options, and the best choice depends on your country context, but also on your purchasing objectives. Broadly speaking, though, we can say that there's two big archetypes of community health programs. There's one model, which we can take Kenya as the archetype, and we'll hear from Kenya later on this call, which is a progressive community health worker professionalization. And by this, I mean that people who were initially volunteers have become trained to become community health promoters, to receive a monthly stipend from the government sources, to be integrated within a primary community care network. And there's a good ratio. In Kenya, for instance, community health promoters need to visit 100 households for which they're responsible every quarter. There's a second model, which is the dual cadre system. And this is quite different because it's countries like Ethiopia who have decided to create an entirely new cadre of human resource professionals, in the case of Ethiopia called the health extension worker. And this is different because it is from the get-go fully professionalized with over a year of training, for instance, but operating usually with a much more ambitious number of households to serve. So for instance, about 1 to 3,000. The way they do this is that they oversee a second cadre, in the case of Ethiopia, the Health Development Army, which there is still usually relying on non-financial incentives and pro-social motivations. I would say that this model is gaining traction with quite a few countries in West Africa and Zambia. Even Rwanda, for instance, is adding a community health nurse assistant model. So, you know, we really see that we have these two archetypes that are happening, and it's for countries to decide which one they want to purchase based on the country context. But there is a common design risk, whether it's one model or the other. We have seen evidence that as community health workers become professionalized, there's a risk that women be pushed out of the workforce because these jobs become more attractive to men. And so there's a real role for the Ministry of Health to ensure that they intentionally protect the gender balance and that women are able to benefit from this professionalization as well. Now, how can community health workers be purchased? Well, if you look at the bottom of this pyramid, the gray, this is unfortunately the long history of community health programs where it was mostly project and pilots and mostly donor funded. But we want to move up. So the second layer, which some countries have moved to, are more performance-based systems. For instance, in Cambodia, through domestic funding now, community health workers are receiving incentives when they test and refer populations for high blood pressure or high blood glucose. In Rwanda and in Burundi, there have also been performance-based model, but this time based on maternal and child health indicators. In Rwanda, it's actually quite a sophisticated model where 70% of the funding goes towards a cooperative of community health workers, which then invest together in income generation activities. But I would say the literature review on this is mixed. There are some questions on whether the performance incentive is large enough to actually matter. And secondly, on whether sometimes it can skew performance towards the health areas that are incentivized. So I would say what is considered best in class is the full institutionalization of community health programs. And this is really looking at the primary healthcare benefit package overall and deciding from there what the community health package looks like, and then funding it either from the national budget entirely, the MOH budget. Secondly, through the local governments. And actually, we've seen some models such as Kenya, where there's co-investment 50-50 between national and local governments. And even the new frontier is looking at payments through social health insurance schemes, which are becoming more popular, for instance, on the African continent, because usually social health insurance scheme, they will have population-based payments to the primary healthcare level. So a share of that can actually be ring-fenced to go to community health level activities and salaries. Now, what's interesting when we look more into detail is that the choices made on the what to purchase and the from whom to purchase are going to influence how services are purchased. So to give some examples, on the what, if community health promoters' role expands beyond strictly health, and for instance, registering people for social protection mechanisms, it's more likely that, say, the social health insurance scheme might be interested in co-investing in them. If they have a role on civil registration or vital statistics, this will be more likely that the local government might want to co-invest in them. But also choices made on the whom to purchase from will also influence the how. So for instance, I would say countries that have gone the route of adding an entirely new cadre of community health workers, it's easier for them to generate from the get-go sufficient pot of funding from the national budget for their salaries because the cohort is created as part of the regular sort of cadres that are overseen by the Ministry of Health, whereas it takes more effort, including political effort, for in the model where it's professionalization of previous volunteers to obtain their duly needed stipends. So there's a question of how to get there, how to ensure that the financing matches the ambition, and in particular, what is the share that goes towards community health worker salaries. Well, what we can notice on the lessons learned front is that this can happen moving from projects to system when 3 stars align. The first star is the technical readiness of community health worker programs. And by this, I mean that the PHC and community health unit in the ministry needs to cost the community health service package. They need to show the investment case, and they need to show that the building blocks in terms of supervision and digital can be in place to really move to a full system. Equally important, we need political feasibility. And often what we'll talk to decision makers is the employment component of ensuring that community health workers now have salaries in vulnerable communities. It takes a lot of effort, and I'm sure that when we hear about Kenya, we can hear the role of community health associations as well in generating basically inclusion in political manifestos of the professionalization of community health workers as an objective. And third, what's important as a North Star is institutional fit. And by this, I mean that there needs to be sufficient dialogue between Ministry of Health and Ministry of Finance to ensure that on the public financial management piece, both the primary health and the community health level can get their payments on time to deliver quality services, because community health workers are vulnerable and need this to month on month continue to serve. And secondly, that these question of commodities, for instance, are smoothly cascaded down to the lowest level. So what doesn't work, on the other hand, and what can we avoid? Well, there's three real challenges. The first challenge is when there's effort to strengthen the community health worker program, but there's not a corresponding effort to strengthen primary healthcare level. And there are still either nominal or hidden user fees at the primary healthcare level. So for instance, people who still need to pay out of pocket for key commodities because there's stockouts, or who need to remunerate nurses that are quote unquote volunteers and actually remunerate themselves through out of pocket. So to be able to see the uplift in child and mortality and maternal health outcomes, we really need to ensure that there is this dual helix. And this is why I put a little icon of a DNA on the left side. On the one hand, a strong community health program, and on the other hand, strong health facilities, that we really start with an integrated view of the PHC strategic purchasing reform. And then we look through a network of care approach, what can community health workers deliver? Referrals and counter referrals included. The second challenge is those programs that were designed where they expected community health workers to remunerate themselves through the sale of health products or medicines. And this doesn't work because it creates a conflict of interest on the part of community health workers who then may lose the trust of the communities that they serve. The third challenge is the challenge of insufficient data quality at the community health level and lack of interoperability between the system that collects data on community health indicators and the system at the primary health level, which collects health facility indicators. Why is this particularly important? This is because it's only by collecting quality data at the community health level that we are able then to use this data to become smarter and optimize. If you remember that orange arrow, the purchasing agreements, for instance, know how to move beyond the rule of thumb on priority areas where community health workers need to be deployed, analyze community health workload and optimize that. We also really need that data to be able to continue to generate interest from the purchaser and the politicians, president included, on what is the value of community health programs? What do you lose if you cut that funding? And so we need strong indicators that will ensure that sustainability of funding. And the third, if we look ahead, is that AI is a great promise for community health because it can allow, right now we're asking community health workers to essentially be Swiss Army knives for bringing reach of health services at the household level. But with AI, they can deliver even precision medicine once we equip them with the best algorithms. But this will require very careful attention to the quality of the digital systems, but also to strong digital and AI security, as well as strong leadership from the governments to put in place the right rules that will keep the trust from the communities. To finish, where are we on community health worker institutionalization? The truth is that though there has been progress, there is still a long journey ahead. This is data from the Africa Frontline First Maturity Assessment across 15 African countries, where they self-rated based on specific criteria for what is a highly functional system on remuneration and financing. And what we can see is that 11 countries still rated only as partially functional on financing and 8 on remuneration. And so there's still a lot more to do. And while this can seem daunting, it's also actually very hopeful and fantastic because it shows that there is still, if you go back to the beginning of this presentation and what Fuzia said, a lot more health impact that can be unlocked and reached if we continue to invest and strategically purchase community health programs. Back to you, Maud.
Thanks so much, Solène, for sharing that global framing presentation, sharing lesson learned from several countries and the potential way forwards. Let's move now with country experience with our panel that will last for the next 30 minutes. This panel will start with a discussion with 2 policymakers from Burkina Faso and Kenya, and at the end we'll hear as well from a community health worker from Kenya. Let me start by introducing our two country representatives. We are honored to have with us Dr. Maureen Kimani, who is the head of the Division of Community Health at the Kenya Ministry of Health, where she's leading the national community health policy, strategy, guidelines, and digital tools such as the electronic community health information system. And Dr. Kimani coordinates community health partners, transcends systems during COVID-19, and supports universal health coverage and data-driven decision-making. With over a decade of experience in community health systems, she has overseen initiatives to professionalize and support frontline community health workers. And we're really looking forward to hear more about the Kenya experience. And joining to share the experience of Burkina Faso, we're honored to have with us Dr. Mahamadi Tassembedo, who is Director of Community Health at the Ministry of Health in Burkina Faso. With over 18 years of experience, he has held strategic positions, including Director of Health Promotion, Director of Monitoring and Evaluation, and District Medical Officer. He is committed to the professionalization of community health workers and has initiated innovative health promotion approaches, such as community health clubs and the Model Household Initiative, enhancing the adoption of preventive behavior among communities. Let's now turn to both of you. First, I would like to ask Dr. Kimani to share a bit about the experience of Kenya toward the institutionalization of community health as part of the primary healthcare system, especially on the purchasing mechanism that are in place. Over to you, Dr. Maureen.
Good morning, good afternoon, everyone, and thank you, Maud, for that very important question. And so I'll just be very brief in talking about what Kenya has done to institutionalize community health, and particularly looking at strategic purchasing. So since 2023, the government of Kenya has formally recognized community health promoters as a key pillar in delivery of primary health care, and this was done through anchoring the community health services within the legal framework. So we have a Primary Health Care Act of 2023, and also ensuring that our national health policies are clearly aligned to the role that community health plays within the entire health system. And for Kenya, we have what we call the community health units. These are the work units where the community health promoters working, and each community health promoter is assigned 100 households where they serve over time. And these are the households where they register the household on our system, the electronic community health information system, and subsequently utilize the digital platform to ensure that they're delivering services to households across the country. And of course, we have more units within the urban areas, or more CHWs within the urban areas, and especially in the underserved areas, such as the informal settlements, and also in the hard to reach areas of the country. We have a big role that the CHWs play in those areas. And so and through the community health, the Primary Health Care Act, we are also able to start the journey towards professionalization and actually change the name of our community health volunteers. So we're moving them from volunteers to community health promoters, who are on a salary that is paid on a stipend that is paid by government. So they are paid a stipend of 5,000, which is almost $30 per month. And I'll be talking a little bit more on how this is financed. Currently, Kenya has 107,831 community health promoters. 70% of these are women. And our CHPs are helping us to deliver promotive, preventive, and basic first aid services to communities across the country. So from a purchasing perspective mode, Kenya has done quite a bit. And I think this is a success story for us within the country and within the region and in the continent, that government can actually finance community health through different mechanisms, as we shall be looking at. So I'd say we have started the journey towards strategic purchasing of community health services, though it is not at 100%. And we have the legal policy and architecture necessary for that. But this remains incremental. We are not at 100%, but we have started that journey. For us, we have a devolved system of government. So we have the county governments who are in charge of health services. And at national level, the national government is in charge of policy, regulations, and all that. So county governments are our main purchasers of health services. And this is following our Constitution 2010. And we know that counties directly from their health budget finance community health units. They pay stipends, they pay the supervisors who supervise the community health promoters, and also the operations, and all this is done within the routine primary health care budget. But that is not yet optimal. It's still not where we want it to be. And so we'd say at the county level, the purchasing is a mix of both input-based and performance-based financing. And then for the national government, because this was not optimal, so when our current government came in 2022, there was a shift in how the support for community health worker programs is being, and we had an agreement between the national and county governments, because according to the Constitution, the two levels of government can work in cooperation and collaboration to deliver on the mandate and to deliver for the citizens. And therefore, the national government came in, and of course, through exchequer funding, taxpayer funding, we were able to support 50% of that, of the community health worker program. Through, we supplied them with the kits, with these necessary tools of work, so that each and every community health promoter, the 100,007, have a kit which they are able to provide the services at the community level. We also ensured that we have provided them with smartphones, because we were moving from paper-based data collection system to 100% digital system. And so we needed to provide and equip the CHWs with the necessary devices to be able to provide digital health services. In addition to that, recently in 2023, we have moved to the social health insurance, and through this social health insurance, there's been a primary health care fund that was established, which again is fully funded by government. And the mandate is to purchase primary health care services from the primary health care facilities. And this includes the community health, because that's the level one. But we know at the moment the fund is not fully optimal. We don't have all the full amount of money we require. And therefore, we may not be providing the optimal purchasing of services, especially from level one. Level two, and from the dispensaries and health centers, which we call level 2 and 3 in Kenya, there's purchasing of those, and some of the services included in the benefits package. But there's ongoing discussion to improve the benefits package so that we can see how they start purchasing the community health services as well. So in summary, I'd say that Kenya has built a strong policy and institutional foundation for community health, and we are not yet fully strategically purchasing from health services, but there's a huge shift towards that, and the government playing a very big role, and of course partners also coming in, filling the gaps, but the government is really on the front line from the last 3 years. Thank you, and back to you, Maud.
Thanks so much, Dr. Kimani, for sharing the experience of Kenya and the progress and the political commitments towards institutionalization of community health worker. Let me now switch to Dr. Tassembedo and switch in French for this. Rebonjour, Dr. Tassembedo.
we would like to get to know the experience of Burkina Faso better. Could you share with us your experience in terms of institutionalizing community institutionalization of primary healthcare in communities, and also how the different strategic mechanisms were implemented? So thank you very much for this opportunity that you're giving us to present the experience of Burkina Faso. Burkina Faso has a long tradition in community health, because since 1985 we had what was called a village, a doorstep for community health, with people who were already working on community health. But the institutionalization began in reality in 2016, when the government made the decision to institutionalize all of this and integrate community health workers into a system. So this really enabled, as you described, what you call the profile of community health workers, to prioritize healthcare in the areas where they work. So these CHWs in the villages, we had 17,640 CHWs corresponding to this, such workers per village. And we defined a harmonized package of services that included preventive activities, those were the main activities, health promotional activities, but also curing, healing services, for instance, for children, malnutrition, neonatal care, and support activities of all types, because we had to feed this information. We were beginning to see how we could build an information system in terms of a community health system. In 2016, with following this institutionalization, we decided to move to remunerating these CHWs based on lump sum. Every worker had $35 per month as an incitement and formalization process, together with other ways of encouraging them. For instance, participation in different encounters, which also increased their motivation. Institutionalization also meant working on entrance in community health, working on their availability. This also meant working on making sure that these community health workers are properly equipped. So the estimates that we had to equip 17,740 such workers, we moved quite far in our security context, which was difficult, that imposed our moving forward even further in community health. We recruited an additional number of 15,000 workers. So we really have a battalion of 32,000 community health workers that are working across the country. And for the procurement policies that are strategic, we started thinking about what have we bought, what do we buy. This led us to review the services package to truly aim at the needs of the population. So this goes from contributions to the community health works, to malaria, to neonatal care, child care, and prevention. So this went through packages where we there is a payment to the CHWs every month. This also led us to review the quality of services, and the quality of services can only be ensured when there is supervision and a connection with these workers. So we have a health personnel that was not used, people who were whom we call the itinerant or traveling health workers, who become the supervisors of the CHWs. We reconfigured the curriculum for training these agents to lead them to be qualified community agents, health agents. So to become sort of the managers of community health workers who stem from the communities, of course. So presently in our system, we have these qualified community health workers who supervise the activities of the community-based health workers. And we talk, of course, about community relays. As concerns payment, this is difficult because we have, so these 32,000 health workers who are currently paid, we moved to a contribution that was mostly partner-based, technical and financial, but we can only draw up a contract with these community agents if we work with the idea of rendering permanent these positions. So we went from a contribution of partners, let's say 50%, to a contribution, a full contribution, because if you take 2025 all year round, the contributions of the state were able to motivate these workers, and that's very important. And we even secured this budget line for the community health workers to truly show the advantage of having such a contract with payment of a salary. We also moved to a system of professionalization that includes all of the different questions I spoke about earlier, namely to offer these health agents, community health workers, to become qualified community health workers. So we are working on bringing these community health workers into this level of qualified workers, which surely will improve the quality of healthcare in the population. Of course, none of this can be done without challenges. There are challenges, and the very first one is the security context that we have right now, but it also leads us to understand that in the absence of formal structures, it is possible to organize the community to enable it to truly ensure health care provision. So this has become an opportunity for us to further improve our community health strategy. The second huge strategy is, as Solène said earlier, is a huge challenge, because you cannot talk about performance of contracts without having quality data. That is the basis for many services provided, where you really need to motivate people. This has to be motivational. So you need an information system for community health that works well in order to have the kind of data you need in order to do this. And the last challenge is also local ownership, because we're working a great deal more on a system where many things come from the center, from the top. How can we ensure that at the local level, that the actors involved, that the local communities, that the community platforms can take ownership of this institutionalization that we proceeded to implement, and follow up on our so that we can follow up on our interventions locally. So very briefly, that is the experience of Burkina Faso with respect to institutionalizing community healthcare. Thank you very much.
Thank you very much. I know that we could talk about both Burkina and Kenya for many more hours. So thank you for being mindful of time. We'll move now to Q&A, going back to what you said about challenges that you have encountered. Could you explain what, for you, were the 2 or 3 conditions for success when it comes to institutionalization of CHWs and professionalization of CHWs. Of course, it started with local ownership, local buy-in to ensure the sustainability of these efforts. We really needed to have buy-in so that we could put in place these different mechanisms for purchasing. The second element were the inputs. We had a strategic purchasing mechanism in place because you need that in order to make payments. Digitization was another important success factor in strategic purchasing, because without that, you're not able to carry out checks and make sure everything's working properly. And lastly, regular payments for CHWs were another success factor. We were able to have a budget line item for this. And now the major challenge is making sure that these payments are regularly made. So those were the main factors for success for strategic purchasing. Thank you very much, Dr. Mohammadi, for sharing that.
Let me switch to English and to go back to the experience of Kenya and Dr. Kimani. Dr. Kimani, maybe if you'd like in 1 minute, because I'm sure there will be additional time during the Q&A to share the Kenya experience. But if you could highlight in your context, what do you see as the condition of success and the challenges that you encounter to set up strategic purchasing mechanism to support performing CHWs programs?
Thank you so much. And writing on from a colleague from Burkina Faso, quite similar for countries that have institutionalized community health. Of course, for Kenya, we needed to ensure that we had formal integration of community health into the wider health system, where we had clearly defined roles for the community health workers, the scopes of work, the supervision structures, and this within our legal framework, and this allowed the counties to be able to budget for community health as a core primary health care function, rather than it just being a volunteer where they can do it when they feel like. But now it's a consistent budget item within the budget, and also moving away from a donor-driven activity. So I think this is a key success if one really wants to succeed in this community health worker program. And then, of course, for us, the evolution of health services further brought purchasing closer to the communities, where counties or our county governments are the main purchasers, and they're responsible for planning, financing, purchasing community health services, and therefore they are able to ensure that they're aligning to the local needs and the local priorities, and also the financing context within those areas. And again, for us, we are fully aligned to the SDG agenda of UHC by 2030, and therefore UHC for us will be delivered through primary healthcare. This also elevated the community health work and gave us political legitimacy. Also at the fiscal space, we're able to get some space there, and this has really supported some of the government support and government-led financing that we see in Kenya. I'd say, of course, we are not yet there. We're not yet 100% with our financing bid, but we are somewhere compared to where we were 3 years ago. And I think some of the challenges we see is that although we have a lot of commitment from our county government, we still see uneven and unpredictable financing, and therefore this causes delays in payment, in timeliness of payments to the community health promoters, which of course affects their motivation and service continuity. We also see quite a bit of inter-county disparity, where we have counties which do a good job in financing and other counties who are not very keen. And therefore, you see disparities, and of course, there's also disparities in partner support. There are counties who have partners who continually support the counties to advocate to the local assemblies where funds are allocated to ensure that the money for community health is consistently there and it's consistently allocated and disbursed for use within the community health space. And then, of course, there's still some reliance in some countries on line budget and program-based budgeting with linkages between financing, output, and performance. And therefore, this limits the financing space. And we also, although I have said we have a fully digitalized system, we still have some way to go in terms of data utilization so that our data can actually inform financing decisions and help us to further make strategic purchasing much better.
Thanks so much, Dr. Kimani. And again, thanks to both of you. I'm sure there will be several questions and perspectives from the Q&A session. To close our panel, country panel discussion, let me introduce Margaret Odera, who we are very happy that can be here with us today. And to hear from her. So quickly, Margaret Odera is a community health worker in Kenya and mentor mother at Mathare North Health Center, focusing on HIV, PMTCT, mobilization, referrals, and follow-up. A mother of 3 HIV-negative sons who benefited from the PMTCT program, she exemplifies its success. She founded the CHW Champions Network, united over 12,000 CHW nationwide, and is leading the formation of a national association with all 47 counties involved. Margaret has received multiple awards, including Mentor Mother of the Year, Heroine of Health, and Community Health Champion. So we are very honored that Margaret is here with us and that to hear from her. And Margaret, can you tell us, as a community health worker from Kenya, could you tell us, can you share with us your reflections on institutionalization of community health program and what kind of and the strategic purchasing mechanism that work for community health workers as yourself and the one you are working with? Over to you, Margaret.
Thank you so much. It's such an honor to be here. Now, I'll just start by what really institutionalization include, my perspectives as a community health worker. Institutionalization should include the legal recognition for community health promoters through policy and law. And what does this mean? This means that we should have policy in place that governs community health workers. Is very crucial because this will give direction on how to have a mechanism that will allow the government to place us on permanent and pensionable commitment. In Kenya, there is no legislation that governs our cadre. We only have policies like CHS, the Community Health Services, the Primary Health Care Act, but we do not have legislation in place that governs our cadres, like doctors and nurses, and so on. And even if our rights are infringed, we have no law that protects us. Other cadres which have legislations in place have job security, they can sue, and when sued, they have a legislature that protects them. Okay, what institutionalization should include is a clear scope of practice, roles, and reporting structures. We should have formal recruitments, deployment, and supervision within the health system. As we know right now, we don't have we have a formal recruitment, but we still are not employed as we are not salaried. So I think this should change. And then institutional also should include the inclusion of community health promoters, representatives in decision-making and policy forums, the way we have started right now. But many other times, community health workers are excluded in decision-making tables because we are not yet fully institutionalized. And if we are included, community health workers, when they speak, they are not taken seriously. We have been given names like non-state actors. So it's like we are in the Ministry of Health and we are outside the Ministry of Health at the same time. And this makes us lack respect from other cadres, even in the facility. And this negative attitude does not build the health workforce. This gives a kind of working parallel, while we know that we are not a replacement of doctors and nurses, but we are a complement. So we should complement each other. And this will come when we are fully included in decision making. And also institutionalization should also include salary. So the link between salary and institutionalization, these two issues cannot be separated. Stipend without being institutionalized is fragile and can easily be withdrawn. Institutionalization without salary is exploitative. For better outcome in our community, we should create dignity for community health promoters and sustainability for government. Paying and fully institutionalizing community health workers is not a cost, as we have heard before. It is high return investment in resilient primary health care and universal health coverage. And this has been proven even by research from the Community Health Impact Coalition led by Dr. James O'Donovan. When it comes to pay in Kenya, the highest paid county is Nairobi, which is from the county, we get 27.15 USD as of yesterday per month from the county. And then the national government tops up with US dollars 19.39, which is not regular. If they can merge, they pay at the same time, it will be less than $50 irregular pay. I keep asking myself, why? I still have that notion of only God can pay us, because if we play such a critical role, must we be priceless? So if every time in meetings, in forums, it is the same song that community health workers play a critical role, they're the backbone, but this does not reflect in our pay. So I think it's high time that we look forward to have a salaried community health worker, a 4S community health worker. We are not asking for too much. We are asking for the minimum wage in Kenya, which is around $116. That is 15,000 Kenya shillings. So institution and pay should go the same way. Like, for example, right now, Kenyan government is planning, is looking forward to be like Singapore. The president and the government is really looking forward to be like Singapore, which is very, very, very key. It's critical. It's something that is good even for the Kenyan citizen. But when we want to be like Singapore, when you look at the Singapore health system, it's very different from Kenya. The community health workers in Singapore are being paid $3,000 per month. So I'm saying this because Kenya wants to be like Singapore. So let's start from the bottom up, like paying the community health workers is not too much to ask. So for that, I think I'll stop there. Thank you so much.
Thank you very much for your perspective, Margaret. That's also so really key to hear from you during this session. Thanks again. Let's move now to our Q&A session. I know there have been a lot of questions. Let me turn to Nuria.
Tons of really good questions, some of which I think will be really useful for us to hear now. And really just echoing a bit what you were saying, Margaret, that there is a bit of a feeling in the audience that there is a risk that all this focus on community health workers is really just an instrumentalization of ultimately health workers who are cheaper than the nurses and the doctors, and to whom we can ask many things. So there's a real tension that I can sense in the room, particularly around the stipends and the amount. So I wonder whether your panelist mode, but I'll hand over to you in a minute, whether there can be any reaction to this tension that is clearly coming through in the questions. Are we just instrumentalizing community health workers? The other theme that comes through a lot is the theme of money again. So it's all very well and good to have undertaken cost effectiveness analysis and to be able to show repeatedly that community health workers are really cost effective. Nevertheless, does that withstand the process of budget negotiation? So in the countries that we have in the panel, would it be possible to hear from them whether the argument of cost effectiveness was useful at the moment of budget formulation in particular? Then there are, and I'll stop at this third question, Maud, questions around whether these community health workers are only relevant for RMNCH and only relevant for low-income countries. Could we not go beyond RMNCH, and could we think about whether or not they are relevant beyond low-income countries? I'll pause here. There are more, but I think you'll have plenty to do with these three.
Thanks, Nuria. And maybe I'll turn to Dr. Kimani and Dr. Tassembedo for the two first questions. If you can answer a bit quickly, that way we'll be sure that we can have a second round of question. And the third one, then I'll ask Solène to provide some global evidence or a reflection on this. So first, Dr. Kimani, would you like to react on the fact that there is tension between stipends, institutionalization, and is it, when we talk about this, is it somehow an instrumentalization of community health workers? And is cost effectiveness analysis were used, and are you using them in budget negotiation with the Ministry of Health and Ministry of Finance? And then I'll turn to you, Dr. Mahamadi, after the answer of Kenya. Dr. Kimani?
Thank you very much, and thank you, Margaret, for your perspectives from the community health worker lens. And yes, I hear Margaret's comment around the amount of the salary. And I'd like to say that, as I said before, is that we are really doing an incremental model in our community health worker program, so that we are starting from somewhere, from zero actually. Before 2022, there was almost zero government financing. And we are incrementally moving, even as we build the capacity of our community health workers, so that we are sure that we have community health workers that are they are well skilled and therefore delivering quality health services. And it has really been incremental through thinking about career progression, guidelines, career pathways for community health workers, so that they don't just remain as CHWs who are paid the little stipends, but we can progress our workforce to another level of service, and therefore have enough ability and evidence to justify to Treasury and to government that we really need this workforce to move now to the next level, because capacity building is done and all these other critical things that can help us move them into the next level 3 in terms of the education background, and now formally integrating them or fully integrating them into the health workforce. And I think the other thing was that did we have cost-effective analysis when we were requesting for this budget from our national treasury? I think, as I said earlier, Kenya has a very clear return on investment document done within the country, and we were able to clearly show our finance colleagues that this was a good area to invest in. and that would surely get returns both in terms of productivity, in terms of health, improving our health indicators, and the well-being of our communities. And so we had the return on investment, and we have several other studies that have been done, small studies across the country that really gave us the evidence, which we were able to present and really share with our finance colleagues before the budget was approved. And I can tell you that since we began, we have incrementally every year gotten additional budget from Treasury. So we are moving from, I think we've got in Kenya shillings about 750 million initially to the current where we're getting about 3.2 billion going into just payment of stipends. And in addition to the other amounts where we have been able to support the training, the kitting, the equipping, the providing of devices, and so forth. And then for us, our community health workers are not just for vertical programs. So we have an integrated community health workforce who are able to provide services to the entire life cycle, from the pregnant woman and the newborn up to the elderly, providing wash services, providing preventive, promotive across the life cohort. So we basically are looking at an integrated service delivery, and we're not, we have moved away from vertical programs. Thank you. Back to you.
And thanks, Dr. Kimani. Sorry, I'm switching to French. Dr. Tassembedo, est-ce que sur ces deux...
Dr. Tassembedo, as regards these first two questions that were asked by the participants in this webinar, how do you see the tensions, how do you see the potential institutionalization of the community workers in Burkina Faso, and do you analyze the cost-benefit ratio in your negotiations with the Ministry of, or between the Ministry of Health and the Ministry of Finance? And rather briefly, I'm so sorry, but we might be able to take a second round of questions. Yes, I will be very brief. We have to say that as concerns the two community strategies that we developed in 2019, 2023, and then 23 to 28, this is going to be supported by an investment case, because we have to show, as part of the implementation of this strategy, how it is possible to get a return on investment for every element that we invest. What is the return we can expect in terms of quality of life for the population? So this is what enabled us, even for the first tranche, first installment, to have a budget line that really supports the CHWs. And I completely agree with Margaret, because when you look at the services package that was entrusted to the CHWs, if we really want to have a good retention rate for these workers, if they spend more time on working on health in communities, then we are going to have to focus on the funding aspect, the salaries of these health workers. And this is what we're demonstrating with the second phase of our strategy, where we were able to mobilize all of the representatives of the elected representatives of the people in the assembly, and shown them what the kinds of investments that we can make if we could move to this payment with a salary, with at least a minimum salary. So I think that they paid attention to what we were saying. So we are in the process of continuing these discussions to look at how we will be able to achieve this payment, a payment that will be aligned with the salaries of the average Burkinabe. This is what I can say, since we don't have much time. Thank you very much. Thank you, Dr. Tassambedo. So sorry, because we only have 10 minutes left together.
Switching to the last question and maybe asking Solène if she would like to share her perspective related to the community health program and the benefit, the package of services and the countries that are implementing community health program.
Yes, there's definitely value in going beyond the package of service for maternal and child health. I think the example of Kenya was provided, but even in high-income countries, several, including even the United States, are using community health workers as a way to address chronic care. Many studies show the power for NCDs, and this is both to ensure that patients that are pre-diabetic, for instance, do not progress to a full need of insulin. It's much more cost effective to have people on metformin and help with lifestyle changes, but also to ensure adherence and for the most difficult diseases, richer countries also look at community health workers in the context of palliative care. In terms of another use, it's for patients who have disability. I remember when I was in Cambodia, for instance, only because of community health workers was a mother who had 2 children, of which one was disabled and could not gain access to an artificial leg. Was she able to make it to the place where the outreach on assistive technology was taking place? Because then the community health worker could help her gain access to appropriate vehicle to take her and her son to the place of outreach. So there's really a big array of services for high and low income countries. And yes, rich countries are also looking at this as a cost efficient, in a sense, or high return on investment. I think that's the better way to put it, area for their programs. I think one more thing to say, and I see that there's debate, is because it's high return on investment, we're not saying that this should be funded at the expense of other patterns of health professionals. We're saying that ultimately it's cost saving once you look at the investment cases for community health, for countries to invest for their priority health areas in purchasing community health services. And this includes drugs. I see some debates in the chat. There is evidence that for community health workers that are properly trained and supervised, it is important for them to have access to drugs. The case of malaria, for instance, comes to mind. There's clear evidence that when community health workers have tests, but also medicines for uncomplicated malaria, they can save many more lives than if they're just providing referrals to the health facility. So by all means, I think this should also be considered as part of the essential package of services for community health workers.
Thanks, Solène. And just, I'd like to ask Fauzia. I think, Fauzia, it would be great to hear as well from you on the instrumentalization aspect of it.
Thanks a lot, Maud. I realize we don't have a lot of time left, so I'll be really quick. I just wanted to make a reference to WHO's Health and Care Workers Compact, which talks about the responsibilities of the state and of partners towards the health workers. And I really appreciated Margaret's comments because they talk about how the community health workers need to be treated exactly the same way that all the other health workers, or in fact, any workers, including ourselves, are treated. We would not expect to be working, dedicating our time, energy, and effort and not be remunerated or taken care of by our organization. Just like that, community health workers in the communities don't just need to be remunerated fairly. That is a big part of it, but they also need to be provided safe and dignified work environments. They also need to have access to the same social protection that other health workers in a country may have access to. And they also need to have access to on-the-job training and a career pathway made available to that. So I wanted to encourage all our colleagues today to please read through the Health and Care Worker Compact. And whatever situation a country finds themselves in, our community health workers are part of our health workforce and need the same care that any other health workers. And then Solène has given a really detailed response, so I won't go into it. I just wanted to say community health workers are definitely not only limited to being useful instrumentally for the RMNCH. There is a lot of evidence of what they can do for tuberculosis, HIV/AIDS, malaria, non-communicable diseases that Solein has gone into, and there is evidence that exists of what their presence in the field and engaging can deliver. But I did want to make a reference to the role community health workers are playing in emergency response, including through task shifting. All the recent major outbreaks, including at the regional level, in their response, community health workers have played such an important role, whether you talk Mpox, whether you talk about Ebola outbreak, cholera outbreaks in countries. And so there is that dividend that comes from having community health workers that are fully supported by systems as well. Back to you, Maud.
Thanks, Fauzia. So we're almost at time, and we're honored also to have our colleague Nick Oliphant from the Global Fund that has a difficult task to wrap up this session that was very rich with a lot of discussion, lots of insight, and a lot of experience. Let me introduce Nick before giving him the floor. So Nicholas Oliphant is a senior specialist for community health programming at the Global Fund, where he supports the strengthening of community health systems and the integration of community health workers into national health strategies. He previously held roles at the Global Fund focused on malaria high burden, high impact interventions, and worked as a health specialist in monitoring and evaluation at UNICEF. He held an MPH degree from Tulane University and a PhD from the University of the Western Cape. Over to you, Nick, for you to close our webinar of today.
Thanks, Maud. It's a tough job, tough act to follow. I'll try to be concise. Firstly, just thanks to all of the panelists and for everyone that's joined and added their questions and comments. It's been a really rich discussion. A few takeaways from me. I mean, from Fauzia, we have the ROI, and we know the ROI is high for CHWs. Question isn't really whether to integrate CHWs. It's really about how to move from vertical donor-driven CHW programs to polyvalent CHWs providing integrated services integrated within national systems and primarily funded through domestic resources. From Solein, we had the need for a clear national conceptual framework for strategic purchasing of CHWs, covering the what to purchase, the benefit package, the from who to purchase, the CHW delivery model, and the how to purchase, including the purchasing mechanisms, learning from what has worked and not worked to unlock, optimize, and sustain the ROI possible through CHWs. From Dr. Maureen Kimani from the Ministry of Health in Kenya, we heard about great progress on the what, the who, and the how on CHW purchasing, as well as a good example of how the ministry has started to put in place the 4 S's that Solein talked about. She talked about the community health promoters in Kenya and their professionalization journey, moving from volunteers to professionals. And while there is work to be done, as Margaret noted, there have been successes along the way. They have started the journey on strategic purchasing. Government has set policy. There's work to be done on legal frameworks. County governments are the main purchasers of health services. There's a mix of both input and performance-based financing. And they've started work on a primary healthcare fund as a part of social insurance, which includes community health. And they're looking to expand the degree to which the services from the CHPs are covered under that insurance fund. So that was great to hear about. From Dr. Mamadi Tassembedo from Burkina Faso, the Ministry of Health in Burkina Faso, we heard about the long tradition of community health in Burkina Faso and institutionalization there starting from as early as 2016, including a definition of the national profile of the CHWs, the who, the national package of services based on population health needs, the what, the national payment mechanisms, including how much and the how. They've secured a budget line for your payment of CHWs, and this has resulted in, this is essentially the 4 S's that Solein has talked about, and has moved the CHWs there towards professionalization. They've also been working on a career path for CHWs to allow them to advance. Again, a great example on the what, the who, the how on CHW purchasing, as well as a good example of the MOH putting in place the 4 S's. He noted some of the conditions for success, including national appropriation of the CHWs, inputs and supplies, as well as strong data systems to ensure regular CHW payment, as well as strategic purchasing. Though he noted that there was work to be done on strengthening the information systems as the basis for strategic purchasing. And then lastly, but not least, maybe most importantly, from Margaret, CHW herself from Kenya, she noted the challenges with regards to not having legislation in place that governs their status, that they don't have laws. She said there's no laws that protect us. They're recruited but not employed as formal salary, with a formal salary per se. CHWs are not always included at decision-making tables in Kenya, but also true abroad. Institutionalization should include CHWs at the table in decisions. Institutionalization and payment go hand in hand. CHWs should get salaries. We need to create dignity for CHWs and sustainability of UHC through primary healthcare by CHWs, and this will be sustainability in the end for government. And she says that valuing CHWs must really be reflected in their pay. So in summary, I think there's been really notable progress. If we look back over the last years and decades, notable progress achieved. There's a journey ahead, as Selene noted. Together we'll get there. We act together in solidarity and we move this forward. Over to you, Maud.
Thanks so much, Nick. And nothing else to add. You closed with summarizing all the rich discussion that we had over the last 90 minutes of together. Thanks so much for the great participation. A huge thanks to all the panelists that were here today. And have a good day. And it's still an ongoing discussion that we hope to continue hold together. Thanks. Have a good end of your day wherever you are.